Welcome, everyone, to today's webinar on virtual GI care solutions with the Pearson Health Technology Institute. I'm Jared Augenstein, Senior Managing Director at Manatt Health, and I'll be helping to moderate today's conversation. Today's webinar will be recorded and will be available for viewing and download next week. With respect to our agenda, we'll start with an overview of the report findings and then proceed to a live Q&A. Please use the Q&A function in Zoom to submit your questions, and we'll get to as many of those questions as possible in the second half of today's discussion. With that, I'd like to introduce Caroline Pearson, Executive Director of PHTI, to present an overview of this assessment.
Jared, thank you so much, and thanks to everybody who is joining us today on the webinar. We're delighted to have you. I'm excited to share results today from the 6th ever PHTI assessment, focusing on virtual solutions for GI care. And it is always great to be able to share a good news story, so I'm excited to do that, but there is a lot of texture and nuance that we're going to dive into today. So if we can get into some of the slides here, I want to first remind you about who we are and what we do. We are really here to be able to help purchasers, being health plans, employers, and health systems, identify high-value health technologies and digital health solutions and drive further adoption of those solutions at scale. And we do that by trying to choose categories of digital health tools that have significant disease burden, that drive high healthcare spending, and that are on the steep part of their adoption curve in terms of purchasers thinking about bringing those solutions into their benefit design and companies really beginning to increase investment and scale their sales. We look specifically at two key features: clinical effectiveness. So these are digital health solutions. They're intended to improve the clinical outcomes for the people that they serve. And so we want to look very carefully at whether those solutions are working and for which patient populations. And then we look at the economic impact to understand how the addition of technology to care delivery can generate healthcare savings and improve economic impact while driving better access and outcomes. At the end of the day, we try to deliver clear recommendations to purchasers about what is ready for broader adoption and which solutions require further evidence generation. So without further ado, I will jump into our findings from this report. I think one of the things as we look at this assessment to understand is that GI conditions drive a significant amount of healthcare spending, particularly in the employer healthcare market, but they're really not a single condition. It is a group of very heterogeneous different conditions which require specific tailored treatment. And when we look at what the recommendations are for really what the standard of care is, what the best-in-class care is, we increasingly see that folks recommend multidisciplinary care that includes both gastroenterologists and other specialists, but also dietitians and behavioral health specialists. However, we also know that many people who are suffering from GI conditions do not have good access to that recommended multidisciplinary care. In fact, there is a significant shortage of gastroenterologists in this country. They have one of the longest wait times of any specialty. And multidisciplinary care is really often built at academic medical centers and may not be broadly available to people who are seeking treatment elsewhere or who live in more geographically distant areas. And so the solutions that we're going to try to talk about today really seek to replicate and expand that multidisciplinary care model in virtual settings outside of academic medical centers. But before we get into that, let's talk a bit more about the conditions that we focused on. So as I mentioned, GI really represents a broad range of conditions. And in order to be able to assess effectively, we needed to narrow our focus into two specific conditions, namely irritable bowel syndrome, IBS, and irritable bowel disease, IBD. And you see here on the bottom the prevalence of those conditions in the US. It's about 6% of individuals have IBS, 1.2% of folks have IBD. And aside from the letters, the two letters that they share, these conditions are really quite different. So IBS is what we call a functional disorder that is really centered mostly around the brain-gut interaction. And so it is really managed with a combination of dietary changes and customized behavioral health therapy that can help target and address that brain-gut axis, resulting in symptom reduction. IBD is different. It is what we call a structural condition. So it actually results in visible changes in the GI tract that can be seen by clinicians through scopes and other procedures. And those individuals, people with IBD, typically rely on biologic medications, specialty medications. You see those advertisements on TV regularly. They may also require more frequent scoping to assess disease progression, and sometimes surgery if there is significant damage to the gut. And as we'll get into it, you see that actually, therefore, the interventions to address symptoms and quality of life, as well as disease progression, ends up being somewhat different for those two conditions. And so we're going to take a look at that specifically. But you do begin to see that, in fact, while these conditions are different, purchasers are really buying a single set of solutions to address all of them. And we want to make sure that we enable each individual to get the care that they need. So as we dive into virtual solutions, we're going to try to explain sort of what the companies that are in this report are really offering. And as I mentioned, these solutions are really designed to be virtual models that replicate that multidisciplinary care experience. So first, you're going to see that there are a variety of what we're calling support services that can be enabled and delivered through digital or virtual means. And that generally includes things like nutrition counseling, trying to understand dietary triggers, and move people into diets that may be less inflammatory, have a lower inflammatory response, and address symptoms. They also very heavily rely on behavioral health support. And these are things like cognitive behavioral therapy, CBT, modules that are designed specifically for that brain-gut axis, and that can be delivered through self-directed content, activities, videos, all of which can be enabled on websites and phone apps. And then there is a component really which is designed not only to support the care experience of patients, but also to try to address some of the spending. So we see here care navigation and symptom tracking, which is meant to help those patients really wrap around their clinician visits and understand when they need to seek additional healthcare services. As you saw in the last slide, people with IBS and IBD tend to have significantly higher healthcare utilization for things like emergency department visits, hospitalizations, and other testing that goes on during those visits, each of which can drive up healthcare spending. And so when patients are experiencing symptoms, they often need a place to go to understand, are these symptoms something that need immediate medical attention, or how should I respond? And so all of those come together into these support services that can really be put together into these virtual solutions. Now, the clinician-led solutions, we're going to talk about these categories, go a bit further, and they combine these virtual support services with that specialist gastroenterologist care, including prescription writing, so medication prescribing. And we'll talk about that in a moment. So in our assessment, we looked at 5 different companies that are delivering these virtual GI care solutions, again, with a sort of comprehensive set of multidisciplinary care services being included. And we've categorized these companies into 2 primary approaches to delivering this care. one that we're calling wraparound solutions. And these are really a patient-centered approach that can complement or wrap around usual GI care by adding those digital support services to medical visits. So a patient may be seeing a gastroenterologist or a primary care doctor for their regular GI treatment, but very rarely are they getting the benefit of those additional behavioral health or nutrition support services in some of those traditional care models. And so the wraparound solutions really put into the hand of the patient those other support services that may be very effective in improving their symptoms and addressing their quality of life. These are often sold directly to health plans or to employers who can contract separately for these solutions and then can engage their members directly to use these services, as I said, alongside any other GI-specific medical care that they may be receiving through their typical medical benefit. The clinician-led solutions, and you see 3 companies here included in that category, they are a more integrated model that puts the specialist gastroenterologist into the center as that sort of core integration component, along with those multidisciplinary care components of support services like behavioral health and nutrition support. And this is often sold again to employers and health plans, but really delivered as part of the medical benefit. So these solutions actually are network providers that can be found as part of the provider network when a patient goes on and looks up how to engage with their GI care. And so it's just a bit different in terms of how they are both sold and then delivered to patients. Now, I will flag here that among the 3 clinician-led solutions, Salvo has a somewhat different business model. So unlike Able and Oshi, which are often, as I said, being sold directly to health plans or employers, Salvo is really built around servicing GI practices. So they are selling into those specialty practices and really helping those providers deliver the full multidisciplinary care experience by offering those digital support services in addition to their medical services. And from a patient point of view, the reason that we've put these into the same category is each of the different sales approaches and business model designs really from a patient perspective seek to integrate those support services with the specialty care in that sort of virtual multidisciplinary care model. I will note that in addition to the 5 companies that we reviewed, there are several other prominent companies that are offering more targeted solutions in this market. They weren't included as part of this assessment, but some of their evidence is described in the report, and I'll just call out 2 of them here. First is Nerva, which is really a prescription digital therapeutic that specifically targets digital behavioral health services and has some very strong clinical data to demonstrate how effective those behavioral health supports can be for people with IBS. And then Sonar MD, which is really focused on the sort of symptom monitoring component of the solutions and really seeks to identify when patients may be experiencing flare-ups or increases in their symptoms to try to intervene before they seek healthcare that they may not require or could be avoided. The other thing that I'll flag here is that this is a rapidly developing market, and these companies are evolving their business models quickly. And so what we're seeing is actually that companies from each of these categories are expanding their offerings and often launching products that might be in the other. So you've got some clinician-led solutions that are making more of a wraparound, patient-centered product available for the purchasers who are interested in that. And vice versa, we see some of the wraparound solutions beginning to integrate specialists so they can offer more of that full stack experience. So as we pivot to the hard technical work that we do at PHTI, our clinical evidence review relies on a systematic literature review across, in this case, again, IBS and IBD treatment. And first thing we do is talk with our clinical advisors that give us good guidance on each of our reports about what is the most appropriate primary outcome. And in the case of our GI care report, we are really focused on symptom improvement and quality of life improvement as reported by patients. One of the things that is complicated or was complicated in conducting this assessment is how many different scales we saw to measure symptom improvement and quality of life. So in the evidence that we reviewed, we saw more than 20 different symptom and quality of life scales. About 8 of those were validated scales, and only one of them has a threshold for a minimal clinically important difference that tells us what magnitude of symptom improvement is really going to be clinically meaningful for a patient. And so as we think about the body of evidence, there is not as well developed clinical scales in this category as we have seen in some of our others, and that's certainly an area for improvement. And then, we also saw a wide range of non-validated scales being used, including a number of scales that were custom designed and created by companies in this report, often to address a wider range of of GI conditions in a single scale. So rather than having one scale for IBD, one scale for IBS, and for others, companies were trying to aggregate into single scales. And while we understand the appeal of that approach, it does make it challenging when you're looking at the evidence to compare results from one study to the next. And so that's certainly something that we needed to reckon with in this report, and you'll see some of that if you dig into the findings. In terms of the evidence base, we reviewed about 1,700 articles and other pieces of evidence, and we had about 41 unique studies that really looked at the outcomes of interest in this assessment. And so that's a pretty moderately sized evidence base relative to what we've seen in other categories, and is generally a pretty good body of evidence from which we can work. As we get into the clinical outcomes, I'm going to take it one condition at a time. And so as I said, the IBS and IBD are quite different, and we really needed to look discretely at what interventions were effective and how much they improved symptoms and quality of life for each of those conditions. So looking at IBS, we see that both wraparound solutions and clinician-led solutions deliver clinically meaningful improvements in both symptoms and quality of life for patients. Particularly, we saw very strong evidence in the wraparound solutions, which had a really robust set of comparative evidence that enabled us to feel confident that relative to usual care, just typical medical care without those additional support services, by adding behavioral health and nutrition support for patients, we see significant improvement in their health outcomes. And so that's an incredibly good news story. As we look at IBD, things are a little bit different. So as we teed up, IBD is really a condition that requires a specialist who can prescribe medications, particularly those biologic medications, and track disease progression more closely. And so wraparound solutions that are delivering behavioral health support to patients are not sufficient to treat IBD. And we did not see evidence that those solutions deliver clinical benefits for patients who have IBD alone. However, I want to highlight that about 1 in 3 IBD patients also suffers from IBS symptoms. And so for those individuals where you have comorbidity, they're going to need to see that gastroenterologist for their medical care, but the addition of brain gut therapy and nutritional support is likely to help with symptom management for those patients as well. And then when we look at these clinician-led solutions, which again are really built to integrate with the specialty care, we see that they are able to deliver virtual multidisciplinary care that is as effective as those best-in-class in-person models. And that's really, I think, a very exciting result, given that we have such strong evidence that multidisciplinary care on an in-person basis is really what we recommend for most patients. Many individuals are not able to receive that care. And so being able to demonstrate that these virtual models, which seek to leave that gastroenterologist at the center, but really expand access and scale those solutions, can be quite effective without being built in on an in-person basis. So now that we've seen that these solutions are clinically effective and can really improve the lives of patients, I want to take a moment and talk at more depth about the economic impact. So in most of our previous reports where we have had positive results, we have seen that some of those digital solutions can deliver care at a lower cost, and in some cases can save money. And typically we're seeing savings in the sort of low hundreds of dollars per user. This is the first report where we are seeing thousands of dollars saved on an annual basis for each patient that is using one of these solutions. And so I think what is most striking in this report is that it is really the strongest economic findings that we have seen in any of our assessments to date. So just to dive in at a deeper level here, I'm going to guide you through this table. So if we look at the wraparound solutions, once again, these are really best designed and most effective for IBS patients. If we assume that about 1 in 4 eligible patients may engage with a virtual solution, you see that prevalence. The IBS patients is one of the most IBS is one of the most common GI conditions. This is going to be the largest volume of patients relative to any of the other conditions. And because these solutions generally have a lower price point, you actually see that sort of $1,900 annual per user savings. That's going to be the largest economic savings for IBS patients of any of these solutions. So if you were just looking to serve IBS patients, the wraparound solutions are going to be a cost-efficient way to deliver the biggest economic return for that large population that folks are serving. But as we said, those wraparound solutions are not well designed and not positioned to be treating IBD patients. And so if we look at clinician-led solutions, those tend to have a higher price point. They're a more intensive clinical model than the wraparound solutions, and so that's more costly. But they really can cover a broader population, given that they can serve both IBS and IBD patients. And so you see here, we're estimating about $1,500 per user per year on average across sort of a normal distribution of people with IBD. But what's interesting is when we look at the clinical data from these companies, we are seeing that the average annual spending for patients is actually not looking like those patients are average IBD patients. It looks like they're serving a more severe patient population that tends to have higher spending. And so if we rerun our model where these clinician-led solutions are only deployed to moderate to severe IBD patients, as well as that IBS population, you see those annual savings estimates increase to closer to $2,900 per year. And so I think we'll talk more about this as we get into some of our Q&A, but it does sort of speak to this notion that when we ask the question of, do these solutions work and for whom, there is a tremendous opportunity if we can target these solutions to some of our higher spending IBD patients to really not only improve health outcomes, but deliver significant savings in the form of avoided hospitalizations and other services. So as we look at sort of how that all comes together into our recommendations, you see that because we have a conjoined report with IBS and IBD, you have to read carefully here, but all of the solutions are effective for IBS. Only clinician-led solutions are effective for IBD. And so you see that sort of yellow and green mix. But all of the solutions will decrease net spending for the entire patient population that we're looking at. And so actually, this is a really good news story for purchasers because they have a wide range of options of solutions that are worth looking at here. Both of these categories warrant broader adoption. We really encourage employers and health plans to look more closely at this category of solutions. And then they really have the opportunity to think about, based on their patient population and sort of how they're trying to augment their existing benefit package, whether wraparound solutions or clinician-led solutions are going to be a more appropriate fit for them. So as we get into final recommendations, and then I'll invite Jared back for some dialogue. I think there's a lot of great excitement here about the potential for digital solutions and the impact on people who are suffering from GI symptoms. At PHTI, we always have to start with evidence generation. We would like to see better evidence about exactly which solutions deliver the greatest benefit and for which patient subtypes. Obviously, we only were able to scratch the surface with two of the leading disease areas here, but there's more to uncover in this evidence base, particularly with some more granular, subgroup analysis. Number two, we would really like to look at durability. So these solutions had moderate duration of study follow-up, but we really don't know how well they get patients to continue to engage with the solution over time. And so what we don't know is, if you use a wraparound solution, for instance, for how long do we see benefits? Do you have to keep using that forever? I think there's a lot of open questions around sort of durability over the long term that would be worth digging into further in the evidence base. The third sort of opportunity is really to think about how to use these solutions to expand access to specialty care. And we can talk further about this, but given the shortages of gastroenterologists, we need to think creatively about how to leverage both the digital solutions and other members of the care team to really begin to make sure that people have access to high quality multidisciplinary care. And then finally, I think there's some opportunities to continue to refine payment models. Many of these solutions are serving a broad base of GI patients with different needs and different spending patterns. And so, simple models that sort of average costs across a patient population may not always tailor the company economics and the purchaser incentives. They may not be aligned in exactly the closest way possible. And so I think as the evidence base grows, there's opportunity to think about some more sophisticated contracting models that might line up those incentives more effectively. But generally speaking, I want to kind of underscore that this is a positive news story and it's an interesting one. And so I'm really excited to invite Jared to join me again and let's talk through it.
Great. Thanks, Caroline. There's a lot of questions coming in, and we'll get to as many as we can. Before we dig into the audience Q&A, and this is sort of picking up actually on a few of the threads in the audience Q&A, I want to just focus in on like the purchaser decision. So it's a good news story clinically. It's a very good news story economically, but there's a lot of nuance sort of at the condition level. And so you made this important distinction between IBD and IBS. Patients with IBD need imaging, testing, biologic medications often, and the wraparound solutions, as you noted, simply can't provide many of those services. For IBD, the clinician-led solutions show meaningful clinical improvement compared with usual care, while the wraparound solutions don't. So can you explain, just again to kind of like put a finer point on this, what the clinician-led solutions are doing that make them particularly effective for IBD, and why the wraparound solutions work well for IBS, but not as well for IBD?
Right. Well, I think it comes back to this notion of really what is driving what is driving that disease. And so, because IBS is fundamentally a disorder of that gut-brain axis, solutions that really focus on behavioral health treatment and nutrition changes can be very effective in helping patients manage their symptoms, right? These are both chronic conditions. They're not going to be cured. And so it is about how do we help patients manage their symptoms and manage their healthcare consumption. And with that gut-brain axis being the center of IBS, we know that digital digital mental health services and other supports can be very effective, and the patient can be in the lead on that, right? They're really patient-led solutions. With IBD being a structural condition, we of course want our patients engaged, but it's not sufficient. We need a lot more, intervention and medications to really slow that disease progression at a structural level. And so that is where it's just very important to have a gastroenterologist at the center of that care. And so if you're a person with IBD that doesn't have comorbid IBS symptoms, that those gut-brain therapies are really not likely to deliver a lot of improvement. And so we want to make sure those folks for an IBD patient, we want to make sure we're getting them into good specialist care as quickly as possible.
Yeah. Okay. I want to come back to the sort of how to think about patients with both IBD and IBS. But before we get to that, so on the economic side, from a purchaser perspective, the evaluation found really substantial cost savings, as you said, more cost savings than for any of the other assessments you've done so far, about $1,900 per patient with IBS for wraparound solutions, and about $2,900 per patient per year for the clinician-led solutions targeting moderate to severe IBD. So they both demonstrate meaningful cost savings, but only the clinician-led solutions work for both IBS and IBD. So if you're an employer or a plan, how do you choose? Why wouldn't a purchaser just go with clinician-led solutions across the board?
Well, they can. But I think it's important to think carefully about what you're solving for. So specialist care gastroenterologists are part of every medical benefit provider network. So it's not as though, most patients don't have some coverage for gastroenterologist care right now. So one thing a purchaser needs to think about is how effective is my medical benefit at serving GI needs right now? And some of that, there's many things about network design that might affect that. But for instance, one might be geography. Our organization is based in New York City, and we have, a plethora of academic medical centers and other systems with multidisciplinary care. If you have a geographically diverse or diffuse population who doesn't have as good access to specialist care, you might be thinking about those clinician-led solutions because you're really concerned about that access point. Conversely, again, if you feel like your medical benefit is delivering well for a patient like IBD patients, then the question is, well, what else can I do, right? How else can I arm my members with tools that can help address their symptoms? And in that case, wraparound solutions are, somewhat they're easy to contract for. You don't have to integrate them into your medical benefits. They have a lower price point, and they're highly clinically effective. So I think there are good choices in both categories.
Yeah. And to bring it back, there's sort of another vector of this, which is it's hard to cleanly split the population of people with IBS and the population of people with IBD. As you pointed out, I think it's a third of people with IBD also have IBS symptoms. And so it's hard to sort of differentiate from an employer and health plan perspective. How does that sort of factor into how the market's evolving and how purchasers should think about how to selecting a solution partner when choosing between wraparound and clinician-led approaches?
Right. Well, if you want, one solution to support every patient with GI care, then clinician-led solutions are going to be the right choice. They have the ability to give those sort of digital support services to people for whom that's going to be all they need, and they can go all the way into sort of integrated specialist care for some of the more complicated structural needs. So they can do it all, and you can sort of put that in place and leave it to them. But I think it's also important to sort of think about where are there opportunities. I mean, the wraparound solutions delivered the greatest net savings of either of the categories for people with IBS. And they're going to help people who have comorbid IBS and IBD. And so there's a lot of value there, I think, for people to consider if that's one of the approaches that they want to take.
Yeah. Okay. So you're a purchaser, you sort of work through sort of that thought logic. Now you're getting to the point of contracting. And so PHTI sort of globally recommends that purchasers align payment with sustained clinical outcomes and reductions in avoidable utilization rather than enrollment metrics or engagement metrics. You spoke about how for the virtual GI solutions, there's many different clinical needs that these solutions are addressing. There's sort of variable savings potential by condition. And there's also a range of measures that are used for evaluating clinical effectiveness. And so how do you contract effectively for these tools? What metrics matter? And how do you account for sort of the significant variability in patient population you're targeting and how you're measuring clinical improvement?
Well, lots of good questions there. So first and foremost, we think that performance-based contracting can be a really important tool to making sure that purchasers feel confidence that they are getting the outcomes that they're seeking. We will be releasing a custom toolkit, a performance-based contracting toolkit specifically tied to this report. And so that'll be coming out, soon. But I think this is one where there are certainly, you can certainly do a performance-based contract on clinical outcomes, but here you would say, looking at those economic outcomes and how to measure them reliably and think about structuring contracts would be a big opportunity because we see such compelling results there. So that's one. Two, I would really urge people to use validated outcome measures, even though they may be more complicated, right? You're going to need to use a different measure for IBS and IBD, and that's not simple, but it is going to be much more reliable, and it's going to allow you as an employer to feel confident that you're getting good results relative to the body of evidence about sort of what kind of symptom improvement matters to patients. So, those validated outcome measures are really critical here. And then, as you think about payment models, this is tricky. It's easy for me to sit here and say, gosh, I want everything to be more tailored to each subcondition of GI and more specific. When we talk with our employers, they say, gosh, I really just want it to be simpler. So the good news is we've got savings for both, for all the conditions here. But you do have to start to look at what are the incentives within kind of if you're paying one price for everyone with GI, what incentives are you creating? And so look, for instance, at our sort of the savings potential for targeting more moderate to severe patients. If you could pay more and encourage a company, a clinician-led company to really focus on engaging those highest cost, highest need IBD patients, that's going to deliver more financial benefit to them and more economic results to you as an employer. And when you have a bundled rate, right, you may be sort of underpaying for some patients and overpaying for others. And so it does start to create some perverse incentives in terms of targeting. So one of the biggest opportunities in this report and in all of them, right, is to say, how do we get more precise about patient engagement and finding those people who are really going to benefit the most from a digital solution? And in this case, actually targeting those high spenders and making sure that the vendor partners have enough in their payment rate to be able to serve those folks well, I think is really important to achieving the kinds of clinical and economic benefits that we're all looking to see here.
There's kind of like there's a targeting focus in terms of contracting, and then there's sort of which conditions you're focused on. And one of the other questions that's come up around performance-based contracting, and you alluded to some of the questions that you have around long-term durability and sort of optimal deployment strategies. That also comes up in the context of contracting. And so, how do you advise that employers and health plans deciding whether to move forward with these solutions factor in the sort of durability questions and deployment sort of optimization questions in the context of how they can contract effectively?
Well, I think, first of all, the results are compelling enough that every purchaser should be looking at a GI solution now.
Mm-hmm.
We hear a lot about sort of point solution fatigue and folks being overwhelmed, But for most employers, GI conditions are their like third highest spending line in terms of chronic conditions. And these results are compelling enough that they mean that folks should, purchasers should really be looking at these categories. We have big questions on durability, but durability is more complicated when you have smaller savings. So, the answer is when you are paying for a patient to be engaged with a GI solution, it is also likely that you are seeing significant avoided healthcare cost. And so when they stop engaging, I cannot tell you right now from the evidence when someone stops engaging with a GI solution if they continue to change their spending trajectory or see better symptom improvement. I don't know that. But because the results are so compelling economically, you don't have to. We should go forward with adopting these solutions while we continue to look at sort of what their long-term benefits are going to be.
Okay, that was really helpful just for getting a couple clicks deeper on sort of the purchasing questions specifically. So let's move to the live audience Q&A. Again, encourage folks to submit their questions. We've received a lot of questions. We'll get through as many as we can. So I'm going to start with the first audience question. So this assessment showed some of the largest per patient savings, I think the largest per patient savings that you've documented in any digital health category, but they still came out lower than what many of the companies are reporting directly. At the same time, you also found that clinical evidence is often lagging behind the economic story, with companies using custom scales rather than validated measures. And so what should purchasers it'd be great to just explain that a little bit, or your perspective on it. And then specifically the question is, what should purchasers be demanding from vendors to ensure they're getting value both clinically and financially?
Well, I mean, ultimately, this is why we felt the need to launch PHTI and to do this work, because we felt like we were hearing directly from purchasers that they just weren't trusting the evidence and the marketing materials that they were seeing. So, part of our job is to kind of cut through that and tell them what we really think, and to give sort of a sober assessment. If you are deciding whether the juice is worth the squeeze to onboard another solution into your benefits package, you want to feel confident about what sorts of savings you can expect to see across your membership. And our numbers look very different than what some of the companies claim. We spent a lot of time digging in on methods, making sure that the assumptions underlying our estimates were valid. And there's definitely some dubious math going on in some of the evidence that we saw. But we feel really confident that there's meaningful savings to be had here, and so hopefully that gives purchasers some confidence that they can move forward and can count on being able to really bend that cost curve with some of these interventions.
And you mentioned that the savings are significant. There's a bunch of questions about sort of what accounts for the savings. Is it reduced downstream utilization, reduction in imaging? Can you just speak a little bit to what accounts for the significant cost savings in both categories?
Yeah, that's a great question. So it's a little different between the two. It is largely big reductions in avoided hospitalizations. That's the easiest one. And then for IBS, you see reductions in ED visits and unnecessary scoping and imaging. And so those are generally the categories. You often see increases in outpatient visits, right? So what we do is you see folks getting more care, the care they need in sort of lower cost, less urgent settings. And so, that's really important. And it's interesting, I spent a lot of time saying like, well, what's driving that? And I do think it's kind of two-pronged. In part, when symptoms are better managed, if you don't have a flare-up, people don't need to seek emergency care. And so some of it is about symptom control. And some of it is, again, about that sort of care coordination and navigation, right? If you are having severe abdominal pain in the middle of the night, being able to reach out, have resources to get connected to, right? Have alternative providers and access points other than, emergency departments. Those solutions can also begin to sort of guide the care. And then interestingly, we heard from some of the companies, like even when folks show up in an emergency department. Some of these companies can really like help avoid what actually gets done to that patient once they show
Hmm,
up. So
interesting.
don't run all the tests, right? Like don't do all of the imaging. Here's what we know about their history and here's what we recommend.
Yeah, that's interesting. That's really helpful. And I would just encourage the folks who are asking about the sort of what's the makeup of the economic savings to read the report. There's a lot more detail in the report about what accounts for the savings.
Yeah.
Um, okay, so next question, coming back to the sort of measures question, or just lifting up from measures, what for patients using these solutions, what does clinical improvement like actually look like, from a patient perspective? And how is it being measured? You sort of talked about some of the challenges with measurement, but what measures are being used today, and what do you view as sort of best practice in terms of where you'd like to see measures headed?
Yeah. Well, each of these measures, and they're all like it's an acronym soup if you get into it, right? So, the IBS SSS is one of the ones that doesn't roll off the tongue. So, as you get into them, you start to see that these are sort of patient-reported measures on both symptoms and sort of how they're living in everyday life. So things like abdominal pain, stool frequency, bathroom urgency, right? These are all things that really affect patient experience for people with GI symptoms. And there are, rigorous scales that can measure improvement over time. And so that's what the scales are doing. But again, we're not measure developers. Measure development is a sophisticated domain, and so validated measures that can really show both consistency longitudinally for a given patient and from patient to patient is what is required to be able to feel confident that when you're seeing progress in a study, that's really reliable.
Okay, that's helpful. There's a bunch of questions about why the focus on IBS and IBD. So the report focuses on IBS and IBD, but they're just two of a long tail of many sort of GI conditions. So just talk about like the choice to focus on those two conditions, and also how applicable you think the findings are more broadly to other GI diagnoses.
Well, as you said, GI is complicated. Like the top 10 GI conditions all have almost equal prevalence, right? So you see this like real wide variety of conditions that have have comparable makeup. IBS is among the most prevalent, and IBD is among the most costly. And so they are representative in terms of spending drivers and patient experience drivers. And then also because they represent those different sort of structural versus functional conditions, they give you sort of a wider array of an understanding of what interventions work for each, right? They're not the same. And we thought that sort of distinction was going to be important. I think everyone wishes that we had been able to look at the 10 top most common GI conditions. And, had we had 3 times as long, maybe we could have gotten there. But the answer is the bodies of literature are discrete, right? The high quality evidence is not conducted across GI conditions. It is conducted for specific conditions, and that is appropriate given that the interventions and the measurement tools are different for each condition. So, in order to do rigorous assessment, we had to narrow our focus and to look really carefully, not to just say it kind of looks like it works, but like very specifically, right? This is what works and doesn't work for each of the subtypes. So that's why we made the decision. Ultimately, I cannot promise that a solution that works well for IBS is going to work for every other GI condition. But I do feel confident when when we look at the efficacy, you can start to say, okay, let me understand the other common GI conditions that I am focused on, and let me think about effective gut-brain behavioral therapy is likely to work for other conditions where that's a valuable treatment. Many other GI conditions do rely on specialist care, and those are likely to be effective based on the IBD findings.
Great, that's really helpful. There's a question about just a clarification. The cost savings numbers, the 1,900 for wraparound and 2,900 for moderate to severe IBD, those are net savings, just to confirm. That includes the cost of the intervention?
Exactly.
Yeah.
Exactly. And it is a little tricky, right? The 1900 is just IBS patients. So if you go into the report, we have more granular tables. So you can see like each category just for IBS and then just the IBD numbers. For simplicity on the webinar, we're giving you a sense of combined results.
Yeah, great. Okay, thank you. Okay, next question is about a policy question. So a lot of the evaluation here sort of focused largely on the commercial market. How do you think policymakers should be thinking about reimbursing, paying for virtual GI solutions? There's been a lot of focus over the last few months, like on the CMS ACCESS program. There's not a GI track at the moment for access, but in general, how do you think policymakers should be thinking about paying for these types of solutions?
Well, given the compelling clinical and economic results here, they do warrant, greater attention from policymakers. The CMMI Access program creates a really good opportunity for traditional Medicare to think about expanding coverage for virtual GI solutions in the context of that access model. And given the strength of these findings, I think that would be warranted as a future expansion. Obviously, the 4 categories that are currently in access tie very nicely to past areas that we have focused on, and so we would be very excited to see this as a future area of growth. And then, I mentioned NERVA earlier as a PDT that has gone through FDA approval. That is not gained, an official payment. That has not gotten payment from Medicare, and so I think we continue to see PDTs delivering value, and so increasingly, I'd love to see payment policy that follows the evidence and the regulatory approvals.
And you're referring there to there's a series of digital mental health PDTs that have coverage in Medicare, and there was some discussion about whether CMS would expand that to include other conditions, but decided not to for this year.
Right, they've decided not to. And PDTs obviously work differently in terms of how they're purchased, and often
Yeah.
being because they're prescribed. But point being simply that NERVA had really strong clinical evidence in isolation, really focused on that behavioral health component that we talked about.
Mhm. Right, right. Okay, there's a whole series of questions here on sort of access and time to diagnosis and sort of more clinically oriented questions. So I'm going to shift to those. 2/3 of US counties lack a practicing GI, which is sort of amazing. What did you find in terms of how well these virtual GI solutions improve access, and are there limits to how far they can scale?
I think there could be. So, the limited supply of gastroenterologists is a problem for in-person care as well as for virtual care. And we can't quickly create more specialists. Obviously, training takes a long time. What the clinician-led virtual solutions really, I think, do a good job of is taking that specialist care at the heart, but building a lot of other providers around them to try to leverage that specialist expertise as far as possible, and make sure that other provider types are able to, and other clinicians can do as much of the sort of surrounding supportive work as possible. So they're kind of getting the most out of each specialist that they employ, and that's going to be important, right? That's something that we need to be thinking about in all of our care models. But as these solutions grow, I mean, these are still relatively small companies. They don't have a huge portion of the market. As they grow, I think a critical question is going to be, they will also face the same, clinician limits that in-person care faces. And so, that may be a real ongoing challenge as these companies seek to scale, and one that we'll be watching for.
Mhm. And sort of similar question related to or the flip side of that, which relates to access, given the shortages. So, many GI patients spend years getting a diagnosis. Part of that is just it can take a long time to see a GI. Part of it is the diagnostic journey, can be intensive. Do you think these solutions can help shorten that journey? And if so, what's sort of standing in the way from scaling up that as a value proposition?
Well, you didn't hear me talk a lot about diagnosis during those slides, and that is notable because when we began, reading and learning and talking to people about GI, the first thing everybody says is, goodness, that diagnostic odyssey, it takes a long time to get a diagnosis. People have trouble getting to the right providers. And, there's a lot of spending. There's a lot of testing. There's a lot of imaging that goes on as part of that diagnosis. And I think everyone in the field recognizes that shortening the GI diagnostic process is an important goal in terms of both getting patients, more quickly to the right care, and also really trying to reduce some of that upfront healthcare spending. So it is important. Unfortunately, it is not something that we see being really addressed effectively by these solutions. And the reason for that is about the mechanisms by which they are currently engaging patients. So, and this is not limited to GI, this is really all digital health solutions, right? Every digital health solution provider is struggling with, how do I get the membership of a health plan or the workers of an employer to know that this solution exists and to decide to engage with it? And unfortunately, in the case of these solutions, typically people are being connected with them once they have had that first GI visit or accrued a lot of GI related spending, right? So they get flagged in the claims, the list gets sent over to the vendor, and then they're doing outreach.
Mhm.
And of course, they're trying to do broad-based outreach, but it's very challenging until somebody's in it. And so often these solutions are just being connected to patients too late to be able to solve that diagnostic issue. And so I think it is important both for these solutions and for purchasers to really think about, given the positive results that we see, could we pull these solutions upstream? What would that look like? How would we get patients in earlier in the process?
Yeah, so area of opportunity, maybe even more potential there. So we've got just 2 or 3 minutes left. I'm going to go to our last question. This is a microbiome question. So there's been a lot of growing interest in the gut microbiome. How did sort of these types of gut microbiome testing solutions come up in the context of this assessment? Are any of the solutions that you evaluated using microbiome-based approaches, and what is the evidence for those types of tests?
There is a lot of hype about microbiome testing right now, both in these companies, in this category and in other direct-to-consumer modalities. At least one of the companies in the report certainly does integrate microbiome testing into its solution and talks about that as a feature. When we dig into the evidence on microbiome testing right now, it is not robust, and it does not support paying extra for microbiome testing. We don't see microbiome testing results being able to translate into health changes and clinical benefits in a way that supports broader adoption at this time. So we'll continue to watch the evidence base there, but recommendations from leading clinical groups have been that microbiome testing is not yet ready, particularly in terms of being paid for at a healthcare system level. Well, that was fun. Thank you, Jared. I really appreciate it as always. And thank you to all of our attendees. I do want to direct you to the full report. Obviously, we do a lot of work, and we think they're very interesting and robust, and I hope that you will too. Please do dig in and feel free to follow up with us about any questions or additional details you have. Thank you for so much active participation in the Q&A today. Keep your eyes peeled for our performance-based contracting toolkit, as well as purchaser guide that will be specifically released as a follow-up to this report. And stay tuned for the next PHTI assessment, which will focus on solutions for chronic kidney disease. And with that, I want to wish everybody a wonderful afternoon. Thank you so much. See you next time.